The occurrence of mitral valve defects, whether stenosis or insufficiency, reaches 8% of the general population and causes increased pressure in the left atrium cavity, which expands over the time. In addition, these patients have morphological and electrical changes in the myocardial wall, with sections of slow and fast conduction resulting in the formation of abnormal re-entry circuits. Pulmonary hypertension in patients with heart failure and heart valve dysfunction reduces the efficacy of surgical valve repair, increases the time for rehabilitation, slows the heart chamber remodeling process, causes rhythm disturbances, and reduce the efficacy of surgical treatment for atrial fibrillation. Despite the data essential above, the current medical practice doesn't have a generally accepted product for surgical treatment in patients with mitral valve dysfunction complicated by atrial fibrillation and pulmonary hypertension. It will be the topic of the next report. Dear Nikolai Trofimov, I am pleased to give you a floor.
Dear Chairman, colleagues, let me express my gratitude to the conference organizers for the invitation and the opportunity to present our results at the 17th World Congress on Arrhythmias in Istanbul. Increasing life expectancy is associated with an increasing incidence of circulatory diseases. Valve pathology reaches 25% of the total number of organic heart lesions and tends to increase, which is confirmed by large randomized trials. Surgical treatment of AF is quite relevant and is a priority task of modern cardiac surgery and arrhythmology. This arrhythmia occurs in up to 85% of cases in patients with valve pathology and is caused by the occurrence of reentry circles. According to different studies, the occurrence of AF after correction of valve pathology varies from 20 to 50%. NIV-ADA's data on the effect of the Cox-Maze procedure on atrial fibrillation in patients undergoing mitral and tricuspid valve interventions demonstrate the safety and efficacy of the Cox-Maze procedure, with results comparable to patients without a history of arrhythmic events. Dr. Hofmann's large meta-analysis reveals a twofold increase in the maintaining sinus rhythm in patients after surgical treatment of atrial fibrillation, but also an increased risk of bradyarrhythmic complications with the possible implantation of a permanent pacemaker. The effect on mortality in the studied patients is recognized as uncertain and requires further investigation. Dr. Farah's study shows better overall survival in patients treated with Cox-Maze 4 compared to patients without surgery for atrial fibrillation. Professor Damiano's study shows us a direct correlation between the effectiveness of Cox-Maze 4 and the size of the left atrium. The implementation of the full box Lesion scheme and the occurrence of tachyarrhythmia in the postoperative period. Many patients with heart valve disease and atrial fibrillation have high pulmonary hypertension. Treatment of pulmonary hypertension remains a pressing problem due to the low effectiveness of the proposed methods. Osorio's work in 1962 proved the existence of baroreceptors in the area of bifurcation of the trunk and ostia of the pulmonary arteries, promoting vasoconstriction of the arterioles of the pulmonary circulation. Recent work by our colleagues from China, the USA and the UK demonstrates good results of endovascular circular ablation of the pulmonary artery trunk using a lasso catheter. Open heart interventions on the trunk and aperture of the pulmonary arteries and the correction of heart valve defects with different technical performance are presented in a number of cardiac surgery centers in Russia. In an animal experiment, we obtained clear morphological criteria for irreversible destruction of sympathetic nerve fibers and ganglia circularly in the adventitial layer of the pulmonary trunk and pulmonary artery. Bifurcation by radiofrequency ablation. The study analyzed the surgical treatment of 202 patients with mitral valve disease complicated by severe PH and AF. Patients' first group underwent surgical correction of mitral disease valve repair or replacement. Patients of the second group also underwent correction of mitral valve defect, as well as the Cox-Maze 4 procedure due to accompanying AF. Patients of the third group underwent a complex surgical intervention, consisting of intervention on the mitral valve, surgical correction of AF using the Maze 4 procedure, and circular PADN. The patients of all study groups were comparable in terms of the main clinical and instrumental indicators. The presented data characterize patients of the third group as more severe in terms of age, Euroscore, left ventricular contractility, left ventricular and right heart dilatation, and pH severity. Surgical correction of mitral valve disease was performed in all studied patients. The main method of correcting the insufficiency was plastic surgery. In case of stenosis, valve replacement was performed with a mechanical prosthesis. The Cox-Maze 4 procedure was performed using a standard technique and was predominantly represented by a biatrial regimen. In the postoperative period, all patients underwent bipolar pacemaker in DDD mode for up to 7 to 10 days. Amiodarone was administered preventively before surgery in saturating dose with maintenance dosage in the postoperative period. Postoperative results demonstrate the benefit of complex treatment, as well as denervation of the pulmonary arteries. The complex treatment group showed better remodeling of cardiac cavities, reduction of pulmonary hypertension, and higher efficacy of the Cox-Maze 4 procedure. Complex surgical treatment allows for better remodeling of the atrial cavities in the postoperative period, as demonstrated on the screen. Reducing pulmonary hypertension, remodeling of the heart cavities in patients with complex surgical intervention ultimately affects the efficacy of the Cox-Maze IV procedure. Creating conditions for the preservation of sinus rhythm and the prevention of relapses of atrial fibrillation. Pulmonary artery denervation was performed using the AtriCure bipolar radiofrequency ablator, which was used to perform the Cox-Maze 4 procedure. The main stages are presented on the screen. The final type of radiofrequency ablation consists of 6 ablation lines, 2 each on the trunk and orifices of the right and left pulmonary arteries. Dear colleagues, we present to your attention a method for correcting secondary pulmonary hypertension in patients with mitral valve defects and atrial fibrillation. The essence of the technique is radiofrequency denervation of the pulmonary arteries by influencing the sympathetic ganglia located in the trunk and ostia of the pulmonary arteries. Due to denervation, vasoconstriction of the vessels of the precapillary bed of the pulmonary circulation occurs and the capacity of the pulmonary blood flow increases, thereby reducing pulmonary hypertension. In practice, the PADN technique pulmonary arterial denervation is carried out using an AtriCure bipolar radiofrequency destructor, which we use in the same patient to perform the Cox-Maze 4 procedure to correct atrial fibrillation. Of course, the main indication for surgical treatment in this group of patients was mitral valve disease, which was corrected surgically. Either mitral valve plastic surgery was performed, mainly for severe regurgitation, or replacement with a mechanical prosthesis for severe valve stenosis. After surgical access, under conditions of artificial circulation, a procedure for denervation of the pulmonary arteries was performed. First, 6 ablation effects on the trunk of the pulmonary artery, then 6 applications each at the mouth of the left and right pulmonary arteries. Access to the right pulmonary artery was carried out from a subaortic approach.